skydive. I just saw that. Somebody put skydiving and ballroom dancing. Yes. Publishing more books. I love that. Keep them coming because it may give me ideas. Not sure if I'm going to skydive, but I like to see that. I do want to ask one question for you to put in the chat. If anyone knows the significance of last Thursday, I believe it was last Thursday, January the 11th, to tobacco control. Does anybody know what last Thursday, January the 11th, signified with tobacco control? What was that date remembered for? Just a couple seconds. I know you're busy typing, maybe hopefully somebody, because it's a very significant date in tobacco control history. Okay, I'm gonna give it because I know Rebecca and Nicolle have lots of good information. It marked the 60th anniversary. Rita, yes, Rita. The 60th anniversary of the first Surgeon General's report on tobacco usage and the damage that it causes. And in 1964, 42% of the adult population used tobacco. Today, it's around 13%. So we have come so far, and we know that different populations, of course, have higher prevalence, and we still need to continue our fight. And that's what everyone on the call is doing. And thank you so much for doing that. But I'm going to stop talking and introduce Rebecca and Nicolle now from the American Lung Association. They have a great presentation coming up. Rebecca Padilla serves as the National Senior Manager for Tobacco Programs and Tobacco Cessation Content and is the Tobacco Cessation Content Expert for the American Lung Association. Rebecca manages a national project that offers expert technical assistance to state, territorial, and local tobacco control programs, health systems, and community partners. Rebecca doesn't just talk the talk, she walks it too. She's a certified tobacco treatment specialist. She's your go-to source for expert insight on tobacco cessation strategies, and she truly understands the importance of this work that we all do. Rebecca has lived with severe asthma and has lost family members to commercial tobacco use. And it's truly her life's mission to inspire change, fuel progress, and champion healthier tomorrows one breath at a time. Originally from Albuquerque, New Mexico, Rebecca now brings her boundless enthusiasm to the Chicagoland area, where she's freezing right now, as we are in Virginia, right? When she's now revolutionizing systems changes initiatives. You'll find her exploring the city with her daughter and 2 German shepherds. So welcome, Rebecca. And we also have Nicolle Mannion. She began her work, Nicolle Mannion, began her work in lung health in 2015 when she founded the state of Hawaii's first support group for patients diagnosed with pulmonary fibrosis as part of her undergraduate capstone project for the University of Hawaii. Nicolle's passion for lung health continued to grow over the years, and she was able to join the American Lung Association in 2019. Since then, her roles with the Lung Association include serving as a health promotion specialist for the state of Hawaii and as a health promotions manager for the special operations team. Nicolle has recently been promoted as the National Director of Lung Cancer Education for the American Lung Association. In this role, she is responsible for managing and creating lung cancer educational content and supporting resources while providing her guidance on the lung cancer patient experience for all of the Lung Association's lung cancer messaging and initiatives. Rebecca and Nicolle, thank you so much for joining us in January, and I'm going to turn it over to you now. Thank you.
Thank you so much for that wonderful introduction. We're really excited to chat with you all today. Really quickly, just want to note that Nicolle or myself have no conflicts of interest or financial relationships related to anything that we're discussing today. And I also want to really note that any and all references to tobacco and tobacco products today within this presentation refer only to commercial tobacco products and not the tobacco and or other plant mixtures that might be grown or harvested and used by American Indians and indigenous peoples for sacred or cultural purposes. So again, my name is Rebecca Padilla. We're here to chat with you today about early detection and how key it is to saving lives and through lung cancer screening and tobacco cessation. So my information is on the screen there for you in case you'd like to reach out to me. We'll be sure we share our contact information with you later in the presentation as well in some wrap up information after today's presentation. So I'm joined by my teammate Nicolle as well. So we'll be kind of flip-flopping back and forth throughout today's presentation just to keep you and us on our toes. So for more than 120 years, Americans have trusted us here at the Lung Association to protect their lungs, whether it's researching treatments and cures for various lung diseases, helping to keep kids off of commercial tobacco, including e-cigarettes, or advocating for laws that protect the air that we all breathe. So our vision is really a world free of lung disease. So with this, our goals are really big. We're striving to defeat lung cancer, to champion for clean air for all, improve the quality of life for those that are living with lung disease, and to create a tobacco-free future. Each imperative that we have is constructed with the idea that achieving this health equity must be the foundation of all of the work that we do at the Lung Association. Because when you can't breathe, of course, nothing else matters. So I want to kick off today's conversation with a quick little pop quiz poll for all of you. So if we can launch our first poll, our question is, compared to other states, Virginia's rate of new lung cancer cases as of 2023, so last year, are above average, on average with other states, or below average. So would love to know. So just, if you can, take a moment. We won't call you out if you get it right or wrong, so don't worry. We'll give everyone maybe another moment or two to answer. And then what do you think when we're ready? Okay, above average, 50% of you thought above average, 46% of you thought average, and just 4% of you thought it was below average rates. Well, 46% of you were on par with that. Virginia is at about the national average as far as new cases of lung cancer has shown in 2023. So that could be, relatively okay news, at least not higher than average. In November of 2023, just a few weeks ago, we released our 6th annual State of Lung Cancer report, which reveals the 5-year lung cancer survival rate for people of color has increased by 17% in the last 2 years. That's great news. This is really helping to close the health disparity gap nationally. Our work is far from being done, though, of course. This report really further highlights how the toll of lung cancer varies from state to state and examines key indicators throughout the US, including new cases, survival rates, early diagnosis rates, surgical treatment, lack of treatment and access, and screening rates. So I urge you, when you have a moment, take a look at this really great report. It's got lots of great information, both nationally and on a state-by-state basis. Throughout our presentation today, there's QR codes in the corner. We'll also be sharing our slides with you after the presentation, so don't stress about having to access these great resources right now. We'll get them all to you. So as I mentioned, the scene in Virginia in 2023, the rate of new lung cancer cases is about 52.4%, slightly lower than the national average rate. Still puts you all on par with being about average in the tier of new lung cancer cases. So over the last 5 years since we started our State of Lung Cancer report, the rate of new cases has improved by 18%. So that's really great news. That being said, though, Black individuals in Virginia are the least likely to receive surgical treatment for lung cancer. So this is a huge area that we are looking to address, not just in Virginia, but across the country. So most people don't know that lung cancer is the #1 cancer killer of both men and women. It kills more people, unfortunately, than breast, colon, and prostate cancer combined. And despite lung cancer being the #1 cancer killer, awareness about it is still very, very low. So that's one reason why activities like this one that you're all joining in today is so important, so that we can feel more empowered to bring awareness about this deadly cancer, bring that cancer out of the shadows so more people understand their risks, understand that they might be eligible for early screening, and they can understand what their options are for treatment if they or a loved one might find themselves with a diagnosis. So I want to give you just a little bit of background on the disease. Lung cancer is a cancer that starts in the lungs. A cancer that starts somewhere else but moves to the lungs is not considered lung cancer. Because of the few nerve endings in the lung tissue themselves, there are very few symptoms in early stages, and most people, unfortunately, don't develop noticeable symptoms until the cancer has spread, when it's harder to treat and the prognosis is worse. There's two main types of lung cancer, small cell and non-small cell, but various subtypes within those types. Small cell lung cancer is almost always associated with cigarette smoking, and non-small cell lung cancer is more common. It usually makes up about 80% of lung cancer cases. This type of cancer usually grows and spreads to other parts of the body more slowly than small cell lung cancer does. Then within that, some people have certain biomarkers that reveal why their cancer is growing uncontrollably. Some doctors say that no two lung cancers are the same. So not every person receives the same treatment. A person with lung cancer will receive one or a combination of the types of treatment, which we'll cover in a few minutes. So with that, I'd like to turn things over to my teammate, Nicolle. Nicolle, can you tell us a little bit more about some of the common risk factors for developing lung cancer, please?
Yeah, thanks, Rebecca. Hi, everyone. It's nice to meet you all. My name is Nicolle Mannion. I am the National Director for Lung Cancer Education. And I'll start today's presentation off on my end with just sharing some more about the lung cancer risk factors. So Rebecca's mentioned this, and I'm sure most of you are aware of the fact that smoking does cause lung cancer. It is the #1 factor that can increase a person's risk of developing lung cancer and contributes to 80% and 90% of lung cancer deaths in both men and women, respectively. Secondhand smoke can also cause lung cancer, so that's another risk factor to take into consideration. And exposure to secondhand smoke causes approximately 7,330 lung cancer deaths amongst non-smokers every year. Non-smokers have a 20 to 30% greater chance of developing lung cancer if they are exposed to secondhand smoke at home or at work. Another risk factor to take a look at is radon. It is the second leading risk factor for lung cancer development and is an odorless gas that seeps into buildings from the ground. If you have never tested your home for radon, especially if it was built prior to 1980 or is an older home, you may want to consider going to the hardware store today after work and grab a radon test kit. They're cheap, usually around $15, and it's easy to test your home for those high levels of radon. So you can also contact a professional about putting in a mitigation system, which is also affordable and not very expensive. It is an easy test to do that could save your life and the life of people living in your home. Other factors that may increase lung cancer risk, like certain types of air pollution or long-term exposure to hazardous chemicals. And also, we really need to consider family history as well, or any history of lung disease at all. A person's risk significantly increases when they have more than one risk factor. And in some cases, it's really not clear what has caused a person's lung cancer, in which case we would, when that diagnosis is received, it would be labeled as idiopathic, meaning unknown cause. Next slide, please. So let's talk about common symptoms or what to look out for. On the screen, you can see some of the most common lung cancer symptoms. Like I mentioned beforehand, and you've also heard Rebecca mention that symptoms don't start usually until later stages once lung cancer has metastasized or spread to other areas of the body. Many of these symptoms, such as a cough or shortness of breath, which are vague, can be confused for other issues like allergies or asthma. So you may have heard your doctor say, we're thinking horses, not zebras, right? Sometimes the lung cancer is one of the zebras and does not pop up on the radar until later on. We encourage people to be persistent with their doctors if they feel like something isn't right or if they do have high risk factors, whether or not that includes a history of smoking. Many doctors really don't even consider lung cancer in people who don't smoke, and that population goes on as misdiagnosed for a long time. However, if someone has symptoms, they should definitely talk to their doctor and make sure that they are being proactive and advocating for themselves with that. Next slide, please. So diagnosis. Diagnosis can be tricky. It can be a lengthy process and often takes some time to rule out other diseases prior to the lung cancer diagnosis. There are several ways to receive the diagnosis officially, but the primary way that we often confirm is with imaging tests. So that is either an X-ray or a CT scan. The X-ray of your lungs may reveal an abnormal mass or nodule in the imaging, and a CT scan will reveal smaller lesions in your lungs that might not be detected on an X-ray. So it's a little bit more detailed. We also have sputum cytology. So it's looking at the cells. Cyto means cell, so it's interchangeable with that. If you have a cough and are producing a lot of mucus or sputum, looking at the sputum under the microscope can sometimes reveal the presence of lung cancer cells. And then we have the more invasive tissue sample or biopsy, which is used for larger nodules or masses. And that is when a surgeon will take a sample of abnormal cells from the lung and actually go into the lung. And we see a lot of, it's just a rougher procedure in general. There's sometimes a lot of pneumothoraxes or collapsed lungs and hospitalizations from this procedure in general. So although it leads to very concrete diagnostics, it is a little bit more of a scarier procedure. All of this information is going to help determine the type, subtype, and stage. So back when a couple slides ago, Rebecca was mentioning the different types. There's two main types, small cell and non-small cell. The non-small cell lung cancer stages go from 1 to 4, 4 being that it has metastasized or spread to other areas of the body. And then for small cell lung cancer, it is staged as limited versus extensive. So a little bit more simplistic as far as staging the small cell. Next slide, please. So let's talk about treatment a little bit, sort of what to expect or what this looks like as far as prognosis and disease progression. Most of you have likely heard of the terms chemotherapy and radiation as far as the universal cancer treatments. Chemotherapy delivers chemicals through the bloodstream to kill cancer cells and also kills healthy cells. So very rough on the body as far as targeting all cells to sort of clean that out and wipe out those cancer cells specifically. Radiation uses high power X-rays or radioactive substances to kill or shrink the tumors. And then we have surgery with lung cancer, which involves removing part or all of the lung and is usually only reserved for early stage cases before the lung cancer has spread. In recent years, the field has made incredible progress in the discovery of new drugs and treatments. Drugs called targeted therapy address the exact mechanism that is causing the cancer to grow, as I mentioned before. And then we have immunotherapy drugs, which harness a person's immune system to fight the cancer. You may have heard of the term precision medicine. Targeted therapy and immunotherapy are examples of this. So you may have also heard of the term palliative care. A lot of people think of palliative care and think of hospice and use those two interchangeably. However, they are very different, and palliative care is more supportive, and it is the special field of medicine that is really focused on helping someone to cope with the side effects from treatment. And it's recommended that patients receive it from the start of their journey, regardless of what stage they're at and their prognosis. So if you know someone going through cancer, ask if they have connected with a palliative care specialist. It does not mean that they're, on the brink of death or needing hospice. It's different. And it's especially helpful if they are struggling with symptoms and side effects. So many people don't even know to ask for this kind of care, and it can really help with pain management and improving and maintaining quality of life. Next slide, please. So lung cancer screening, how do we catch this early on to have a better prognosis and to be exposed to less of the harsh invasive treatments? Lung cancer screening is our primary awareness and prevention tool. And I'll tell you a little bit more about it now. So in 2002, the National Lung Cancer Screening Trial launched. It enrolled over 50,000 current and former heavy smokers ages 55 to 74. It compared two ways of detecting lung cancer in people without symptoms through low-dose spiral CT or LDCT and the standard chest X-ray. Results showed that screening individuals with LDCT scans could reduce lung cancer mortality by 20% compared to that chest X-ray. So the findings were pretty significant with that. So next slide, we'll have a polling question on screening criteria just to gauge your knowledge. So the USPSTF recommends which of the following groups of adults to be screened annually for lung cancer with low-dose computed tomography or LDCT. And go ahead and put your answer in for which one of these options you think is our primary screening population. Just give it a couple seconds, and I'm not sure if I can see the results here. But the correct answer with that, all right, so we're spot on. The correct answer is B. Adults age 50 to 80 years who have a 20-pack smoking history and currently smoke or have quit in the last 15 years. So great job, you guys. Next slide. So let's talk about screening eligibility and insurance. Since 2013, the USPSTF, or the United States Preventative Services Task Force, gave use of low-dose CT scans for lung cancer screening a B recommendation, which means that under the Affordable Care Act, most people meeting the criteria for screening that have private insurance will have coverage without a copayment. This was followed by a similar decision for the Centers for Medicare and Medicaid Services, or CMS, back in February of 2015 to cover screening for a similar, although not congruent, at-risk population. They cover screening for those ages 55 through 77 as opposed to 80, which is certainly helpful for not being very far in age. And then coverage of lung cancer screening in Medicaid varies by state, and currently this is covered in Virginia. So contact your Medicaid program or managed care plan to find out if screening is covered for you. Next slide. So who should be screened? Again, just as we stated in the poll, the current USPSTF screening recommendation specifies that people between 50 and 80 with a 20-year pack history of smoking, meaning that you smoked a pack a day for 20 years or 2 packs a day for 10 years, and are a current smoker or have quit within the last 15 years. So this is definitely some tricky wording to nail down. However, we want everyone to be very aware of the criteria so that you can understand whether or not you are eligible. And if you are working in cessation, then you can have those ready to go in case there's someone who should be screened and who has not been yet. If someone has symptoms and they get a CT scan, that is considered as diagnostic as opposed to screening. So why wouldn't we just screen everyone for lung cancer? Well, screening tests have risks as well as benefits. It is fairly new, as we mentioned, it just came out in 2002. So in the highest risk groups, screening tests have been shown to save lives because the cancers are detected earlier when they are easier to treat and before they have spread. However, if we screened everyone, we would probably find a lot of false positives and perhaps do procedures that could be dangerous for someone who is healthy, such as a biopsy, or even starting chemotherapy with that false diagnosis, which is, not the direction that we want to go in. Not to mention the unnecessary psychological burden this would carry with that misdiagnosis rate or false positive rate if we were to sort of widen the lens. So hopefully in the future, we will be able to have better screening tests that can be used for more people. But as of now, it's really only recommended for those within the age range with the smoking history that I mentioned. You can scan the QR code on the screen to visit our Save by the Scan page and learn more about accessing resources and taking an eligibility quiz. So I'll share more about Save by the Scan on our next slide. So we know that lung cancer screening saves lives by detecting the disease at an earlier stage when it is more treatable. The Save by the Scan campaign, which you may have seen in ads, throughout the country, we've got it circulating on TV and on billboards. It is a popular resource that the Lung Association frequently promotes, but it is a campaign that continues to help current and former smokers learn about the life-saving potential of lung cancer screening. In 2021, 180,000 people took our Save by the Scan eligibility quiz, and over 25,000 were found to be at high risk. We really encourage all current and former smokers to visit this website and to take the low-dose CT screening test and eligibility quiz. And if you don't have computer access, you can also call 1-800-LUNG-USA, and a lung helpline specialist can help walk you through the assessment and discuss the results. After taking the short 5-question quiz, it determines that you might be at risk for lung cancer and if you qualify for a low-dose CT scan, so that the individual can then download a conversation guide and discuss next steps about getting that screening referral with their primary care provider. For those who work in cessation, we recommend integration of this life-saving resource in your day-to-day interactions and interventions with smokers. We know that this saves lives, but setting up a screening program itself can be complicated, and we do have a implementation guide for screening to help guide other institutions and community-based organizations through the process of how to design, implement, and conduct their own screening programs in hospitals and health systems. When guidelines for those who qualify for screenings are changed and people need to look those up, we also have new USPSTF lung cancer screening recommendation toolkits to help find people find out if they do qualify for this screening. You can also scan the QR code on the screen and visit our Save by the Scan page to learn more and access resources, including that eligibility quiz. So I'll turn things back over to Rebecca now to take us into another poll. Thanks, Rebecca.
Thanks, Nicolle. So Nicolle gave us a ton of great information about screening, but I would love to know from all of you out there, what do you think is the biggest barrier to lung cancer screening? So as you think about this, give us an answer. Again, there's multiple correct answers, lots of different barriers that different individuals encounter, but I'm really curious to see what all of you think might be the biggest barrier. And we'll give everyone a few more moments to answer some things to consider: access to different screening centers, the cost associated with screening, coverage, eligibility for screening, patient education, provider education, stigma or a fear of diagnosis, transportation to get to a screening might be a big barrier, or something else that's not listed. If you choose something else or that other option, we would love to know what you think a barrier is. If you can just drop it into the chat for us, we'd be really curious to see what that is. Awesome. So I think we've got our results now. It looks like biggest barrier that you all think is stigma or fear of diagnosis, followed up second by patient education, And then coming in third, it looks like cost associated with screening. So we're going to go into some of the most common barriers now. So thank you so much for sharing your thoughts with us. I want to point out that the American Lung Association is really committed to helping eligible folks access life-saving screening by increasing lung cancer screening rates among residents in several communities across the nation through our lung cancer screening initiative. So this initiative works to integrate public health equity best practices through building awareness and reducing barriers to care, as well as increasing early stage lung cancer diagnosis and reducing morbidity and mortality rates among eligible patients. It's a multifaceted program, and we could talk about it for hours. We're very excited about it. And it's got a lot of moving pieces, but I just want to highlight on some key points for you all today. So this initiative is taking place in a few key communities across the nation, and it's a replication of a large statewide lung cancer screening project here in Illinois. And we have similar projects going on right now that have just started in Nevada, New Orleans, North Dakota, and San Diego. So although these lung cancer screening projects are relatively new to the Lung Association, we've had some really good outcomes with that larger project that we've done here in Illinois. We've partnered with multiple grant-funded health systems and community-based organizations to really help spread education and awareness about who might be eligible for screening. We have registered 6 different health systems as being a Lung Association Freedom from Smoking Facilitator training sites. We've worked with 7 locally trusted community-based organizations, and all of this work has a huge trickle-out effect to raise awareness and consequently save lives. So to carry out these projects, we do have a series of project objectives. So primarily, they're focused in 3 key areas. So we look at patient support, quality improvement, and finally education, which of course is producing and disseminating new community-based and culturally competent lung cancer screening education and getting the education out to residents and patients within those specific project areas. Oop. Let's see, I think I may have gone 1, 2, okay, sorry about that. So some of the best practices that we have learned from our work in this space, I wanted to bring and highlight to you all today. Some of the barriers that we have really identified in identifying those eligible patients is just basic lung cancer screening awareness. That's a huge barrier. Folks don't even know it's a possibility and that it's, you know, non-invasive, it's not painful. LDCT scans are relatively safe for those that qualify. There's also a lot of demographic, geographic, linguistic, and health literacy barriers to address. And those are very much community specific and vary from region to region. We've also identified that lung cancer stigma, just as many of you identified today, is a huge barrier to address. And that stigma includes healthcare provider implicit bias. And establishing trust is really key. Nicole's going to talk a little bit more about stigma in a few moments and the importance of looking at that from multiple perspectives. So we have learned that really early detection saves lives. And we do this through really highlighting that state level lung cancer burden. And certain communities, of course, are less likely to be screened. So those are the communities that we really try to engage folks and get them to learn more by engaging with trusted professionals in their community. So there's a few other best practices on the screen, but we have a lot to cover in just a few more minutes. And don't worry, we'll be sharing all of these slides with you as well after today's presentation. We've also looked at the importance of integrating and ensuring that we have robust tobacco cessation integration in our systems across the country, especially within these systems that we're doing lung cancer screening. This is really the key foundation on which we build in that lung cancer screening opportunity. So we look at one of the biggest barriers is a lack of prioritization. A lot of times, unfortunately, looking at treating tobacco use disorder is just not prioritized within a health system. And this is a huge cultural shift that we have to work continuously to build upon. It's especially critical in certain settings, such as behavioral health settings, where it's often deprioritized in favor of treating other substance use disorders. When we've seen lots of great data and results from co-treatment of comorbid substance use disorders. So using, of course, going back to the demographic, geographic, linguistic, and health literacy differences, that's always going to be a barrier in any of these key focus areas in integrating both cessation and lung cancer screening. And really looking at using our technology for our benefit. So leveraging the capacity and capabilities of our electronic health record systems is really key in really integrating a robust tobacco treatment protocol, as well as integrating lung cancer screening protocols into a system. This is so important, and it helps with patient motivation to quit. It can also help identify any barriers or challenges that providers might have in educating their patients or prescribing some of those FDA proven effective quit treatments for their patients that might be eligible. So again, I want to highlight that access to tobacco use status is critical, and screening for tobacco use status is so important for every patient, every visit, every time. Another key area that many of our partners that we've been working with over the last few years on our lung cancer screening initiative have expressed is difficulty in collecting data on follow-ups after a shared decision appointment has been made where a provider and a patient discuss what their options are for screening, following up after the initial scan, or following up after a missed appointment, due to the inability to track through their EHRs, and again, a lack of prioritization by providers or support staff. The ways the patients are reminded to return for their annual screening is really a critical element of integrating a robust screening protocol alongside cessation protocols within a health system. And without appropriate resources, patients can get lost and simply will not receive the encouragement that they really need to get back to doing annual screening or following up with them to ensure that they're getting the support that they need to quit if they do or don't qualify for a screening. So we found some good strategies for this. Oops, sorry about that. We found some great strategies here, including establishing a certain follow-up cadence for following up with patients. That's critical for staff, sending follow-up notifications, really leveraging the technology for automated follow-up reminders within an EHR system, and working with those skilled EHR analysts and IT professionals within health systems to make sure that the EHR technology is being used to the best of its capacity. So again, the biggest barrier, though, the kind of overarching barrier that we see is stigma. And that's really one of the most nuanced and most difficult to address when we're looking at lung cancer and lung cancer screening. So Nicolle, I'd love to turn it over to you to talk a bit more about lung cancer stigma and screening stigma with patients.
Sure. Thank you, Rebecca. Such great information on the health systems change work. And a really critical component to addressing the significant barriers and disparities in lung cancer screening. So what do we mean when we're talking stigma? It's important to bring this up and really address it because unfortunately it goes hand in hand with the term lung cancer. Because of the disease's connection to smoking, the public often adopts a blame the victim mentality, or you asked for this because you have a history of smoking, and we are, for the most part, very aware of the health consequences of smoking. So when someone reveals a lung cancer diagnosis, they often hear the question that, implies a lot of blame with, well, did you smoke? People with and without smoking histories, though, report this question as being hurtful and really harmful to their mental health and very burdensome to carry with them as that label. Even though most people don't ask it to be hurtful, it usually is the way that the person providing the question can gauge their risk. It makes lung cancer patients really feel unsupported and like they're not as within or integrated in the cancer community overall. So there is a sense of being an outlier and of not being included with other cancers. So when people do reveal that they have another type of cancer, they are usually met with support and compassion instead of questioning behavior. One reason why we talk about the stigma is because of the negative aspect that it brings to the entire lung cancer experience. And it makes people less likely to seek out and receive treatment or even receive a screening in the first place. The public is less likely to rally around the fight for the disease and therefore doesn't get the research dollars behind it that it really needs to address the morbidity and mortality rates that we're seeing. So what can you do to help fight the stigma? I'll talk a little bit more about our resources on the next two slides. But firstly, if someone does reveal that they have lung cancer, you want to be careful of the language that you pick and limit the blaming statements. And we recommend not asking directly if they have a history of smoking or did you smoke. Instead, ask what you can do to help or if they need anything. You can also let someone know who meets the criteria for lung cancer screening to encourage them to go and get screened. And if someone has symptoms like a nagging cough, you might encourage them to talk to their doctor and at least rule out lung cancer so that they know, that's not one of the fights that they're up against. You can also get involved with efforts to raise awareness, such as Lung Force or our Strategic Cause campaign, which I will jump into on the next slide. So our Lung Force heroes, we're always looking for individuals, healthcare workers, and patients alike who are interested in becoming a hero by sharing their stories. We also want to know how this initiative is making an impact amongst any patients or individuals that you may work with in the cessation world. If there is a patient or colleague that comes to mind, consider sharing the link or QR code on the screen. We're also looking for those who may be interested in representing their community by sharing their voice and their story with senators and members of Congress about the importance of both quality and affordable healthcare, as well as research funding for better treatments and early detection of lung cancer. We encourage you to join our Lung Force Advocacy Day class of 2024 and participate in our year-round advocacy programs and come in person to our Advocacy Week in Washington, D.C. in March. If you are interested, please reach out and I can connect you with the appropriate member of our advocacy team within the Lung Association staff. And you can also use this QR code to find out more about Lung Force and how to get involved. Next slide is on increasing awareness. Lung cancer is the leading cause of cancer-related death, both of men and women, which is a fact that many Americans are still unaware of. We have our Lung Force initiative, which continues to make progress in changing that, and more people than ever before are surviving. However, we still need to raise awareness, increase research funding, and provide education and support for patients and their caregivers. And then throughout this month, we are also sharing new lung cancer data that indicates the progress made against the disease and also offers the opportunity to raise awareness in an effort to save more lives. Our Lung Health Barometer provides a critical look at public awareness and attitudes regarding lung cancer. And we have a national representative survey that has found 29% of Americans know that lung cancer is the leading cause of cancer killing in men and women. 69% of adults have not spoken with their doctors about their risk for lung cancer, and 44% are concerned they may get the disease. Although it is the leading cancer killer of women and men, only 10% of adults understand that lung cancer is amongst the most likely cancers to affect women, while 35% knew that it was among those likely to affect men. And finally, only 36% of respondents knew that lung cancer screening is now available for early detection of the disease. Next slide. So ways to reduce lung cancer deaths. Besides sharing your story as a hero, you can also do a lot to promote tobacco cessation and lung cancer screening. You can work to refer the programs to those interested in quitting tobacco use and offer evidence-based cessation programs. And if you are that cessation program provider, you can also help by integrating Save by the Scan to your cessation programs and resources so that that resource gets inserted into your interactions with people that you help to quit tobacco. Tobacco treatment and lung cancer risk assessment can be included in existing medical and behavioral health programs as part of an overall and comprehensive approach to recovery and wellness. Promotion of screening can be integrated in a wraparound program and service model, so that includes components such as case management, housing and employment placement assistance, and other clinical and non-clinical programs that often work alongside of behavioral health programs. So that's all I've got on my end for today, and I'll turn it over to Rebecca to tell us more about additional resources that we are sharing with you.
Thanks, Nicolle. So yeah, we have lots of great resources. Again, y'all can scan the QR code on the screen. We will also be emailing those out to everyone that registered and attended today. So happy to help you with that. If you have follow-up questions, you can always reach out to us at the Lung Association as well, and we're happy to support. We have lots of great community toolkits. We have community toolkits that are really focused on specific communities, from Indigenous and American Indian communities to Black community members to Spanish-speaking Hispanic or Latino community members. We also have a great toolkit on addressing the stigma of lung cancer. So really wonderful resources. We're always updating and adding to these collections as well. So I invite you to take a look around lung.org. We have tons of great information through our lung cancer helpline as well, where folks can call in, get additional information on screening and eligibility, as well as get directed to their state quit line. We even have lung cancer helpline referral forms for providers and health systems. If you're looking to integrate lung cancer screening or referrals to our helpline into your system, we're always happy to support and talk to you more about that. And we have tons of resources for technical assistance. So if you are a provider at any level, whether you're inpatient, outpatient, behavioral health, substance use disorder treatment, or beyond, our team at the Lung Association and our cessation TA team, we are always happy to help with, workshopping issues with your workflows, with protocols, with EHR systems to best leverage your capacity to really provide evidence-based tobacco treatment and lung cancer screening protocols for those that you serve in your community. So we're always happy to help with that. There's never, ever a charge for our cessation technical assistance. And we have some great patient engagement resources that are coming soon as well, including a lung cancer virtual support group and a lung cancer support group facilitator program. So stay tuned for that. You can reach out to us at the Lung Association if you're interested in learning more about those two programs that should be coming out very soon. So with that, we have just a couple of minutes left. I kind of rushed through those great resources because I know we have some Q&A. So I would love to see if there's any questions that Nicolle or myself might be able to answer for folks today.
Thank you, Rebecca and Nicolle, so much. This truly is life-saving information. And so I'm so grateful you could be with us today. My personal question was around stigma, so I really appreciate the time you spent really talking about that. But we do have a couple of questions that maybe we could just address very quickly before I turn it over to Gina. And one, can you reiterate, is this an annual screening? If no cancer is detected, is this an recommended annual screening for those that meet the criteria?
I can take that. Yes, it is. It's recommended, as long as they fall within USPSTF recommended guidelines of that 20-pack year history, being a current or quit within the last 15-year, person that uses cigarettes. It is recommended on an annual basis. Again, there's that shared decision-making appointment that's critical for the provider and the patient to really discuss and see what's a good fit. But once the screening, starts, then we want to make sure that annually that folks are reassessed to best catch a diagnosis as soon as possible.
Great, thank you. And are there any suggested guidelines or screening guidelines for those who are exposed to secondhand smoke?
That's a great question. And that's a concern that's very near and dear to me personally, as someone that was exposed to secondhand smoke very heavily growing up. That's a huge concern for folks. Also, huge concern for folks that maybe used cigarettes earlier in their life, but they're past that 15-year mark. Maybe they've been quit for 20 or 30 years. Maybe they're a bit younger, but still heavily use those products, right? And don't fall within the certain guidelines. As it stands right now, insurance companies do follow the USPSTF recommendations. So that being said, anecdotally, we do know that sometimes, folks have gotten coverage for screening through private insurance if it's warranted by their provider, and they go through the additional protocols that are necessary to achieve a pre-qualification for that screening. Also, we've seen anecdotally in different screening centers around the country offer a discounted rate for folks that maybe don't have insurance coverage for the low-dose CT scan and are able to pay out of pocket. Still very cost prohibitive for some, looking at a few $100s. But still, if it's something that's prioritized, we always advise folks to talk to your doctor or your provider. That's the first step to really see, if you had a high exposure rate. Do you have symptoms right now? Do you have shortness of breath? Is it due to asthma or allergies? Is it well controlled? Are you getting the follow-up appointments you need with a pulmonologist? All of these are key factors that can play into really help alleviating someone's concern about their risk.
Great. Thank you for that answer. Gina, I'm going to toss this over to you. Although there were some other great questions, by the way, I think we're just going to ask them to come back and do a whole webinar on some of your questions. So thank you all for putting those into the chat.
Great, thanks, Sarah and Rebecca and Nicolle. Thank you so much. It's great information. Like Sarah, I really appreciated your thoughts on the lung cancer stigma. I think it's something that all of us need to be mindful of as we go about the work that we do. I also felt very strongly with what you said about the importance of your relationship with your provider, right? So that provider needs to be very involved in this process, and really needs to. In one of your studies, you said 73% of respondents said that they had not talked to their provider about it. And I really feel that their provider should be the one to talk to them about it, right? To know their screening, they know their tobacco use. So I think that partnership and our work and how we get the providers to know about the screenings and to be very proactive is very beneficial in this work. So thank you for bringing all of this great information up to us. And definitely we will have you back sometime, because we know you bring a lot of information to what we do in the field. I meant to say this earlier at the very beginning of our webinar, but did not. But we have some really great news with our tobacco control program. Today, January the 16th, we have a new member that has joined our tobacco control team, Natalie Gospodinov. And I hope, Natalie, I'm saying that right. She is on the call. She's not on video. She's one of the participants, but today is her first day as a Northern Region Regional Coordinator out of the Fairfax Health District. So welcome, Natalie, and she will be introduced to you all next February, or this February, for our next webinar. So I would like to invite you all to join us February the 20th for Taking Texas Tobacco Free speakers that will be joining us to really talk to us about how we can bring tobacco control work to our behavioral health facilities in Virginia. So I know a lot of you on the call are from behavioral health facilities, so please join us February 20th for our next Tobacco Free Tuesday webinar. Enjoy the rest of your January. If you're getting snow or ice, stay safe, stay warm. Nicolle, I think you're probably in a great area. I know the hottest right now, but I know Rebecca's in freezing temperatures, and I know the rest of us are as well. So everyone stay safe, and we will see you again in February. Bye.